Good evening. I'm John Lynn Jefferies. I'm the Director of Advanced Heart Failure and Cardiomyopathy Programs at Cincinnati Children's Hospital Medical Center. We welcome you to our live event this evening on cardiomyopathy and genetics and welcome all your questions. With me is Dr. Ivan Wilmot and Erin Miller, and they'll both tell you briefly about what they do with our program.
Good evening. I'm Ivan Wilmot. I'm a pediatric cardiologist at Cincinnati Children's, specialize in cardiomyopathy. Glad that you're joining us this evening.
Hello, I'm Erin Miller. I'm a cardiac genetic counselor. I meet with patients and families and provide genetic counseling and facilitate genetic testing for individuals that either have a diagnosis of cardiomyopathy or have a family history.
So just to speak briefly about our program, we follow one of the largest cohorts of outpatient cardiomyopathy patients in the world and have an extensive multidisciplinary clinic of which consists of cardiology providers as well as subspecialty providers in cardiovascular care. They're very pertinent to patients with heart failure, such as electrophysiology, cardiac catheterization, and advanced imaging in the form of magnetic resonance imaging or MRI and cardiac echocardiography. We also employ a large amount of genetic counseling and genetic testing in our clinic, and that serves as part of the substrate for the discussion this evening. And as I said, we welcome all of your questions. And just as a disclaimer, we may not be able to get through all of the questions this evening, but if we don't, we will definitely do our best to offer a written comment following the event this evening. So with that, we'll look and see if we have our first question available. And our first question is related to peripartum cardiomyopathy. And does peripartum cardiomyopathy something that warrants consideration of genetic testing? So just for those folks tuning in, peripartum cardiomyopathy is a cardiomyopathy related temporally to pregnancy. And I'll ask Erin her thoughts about genetic testing in this particular clinical scenario.
Sure. So there's a bit of literature out there regarding the underlying cause of peripartum cardiomyopathy, and I think it's pretty well known that there is a percentage of cases of cardiomyopathy diagnosed in that particular time period that share the same underlying genetic cause as a familial dilated cardiomyopathy or a familial cardiomyopathy. So I think certainly genetic testing should be considered in any case of peripartum cardiomyopathy. While the yield of testing is difficult to pinpoint, it's pretty well known that there are a subset of individuals with that diagnosis that have an identifiable underlying genetic cause.
And I would agree. And just to add on that, many patients have subclinical cardiomyopathy prior to pregnancy and have never undergone screening imaging, so they may have had pre-existing myopathic disease. We also recognize that many cases of peripartum cardiomyopathy have a subset of cardiomyopathy called left ventricular noncompaction, which would predispose you to myocardial dysfunction long term. So if you went into pregnancy with substrates such as LV&C, the stress of pregnancy, the hormonal changes that go on, and the volume shifts that go on may predispose you to adverse remodeling of the left ventricle, and that could result in heart failure symptomatology, which would ultimately lead to patients being screened and imaged in the form of echo or other sorts of testing. So there is absolutely a good reason to consider genetic testing. The other piece would be assessing for any family history or other things that might increase your pretest probability of having a positive genetic test result. So great question. Thank you for that. Next question, can the results from testing tell us the likelihood of my son developing severe heart failure? So Dr. Wilmot, would you like to take that?
So I think with the results of testing, it really depends on what type of tests have been done on your child, and similar to what Dr. Jefferies had mentioned, the pretest probability. So for some families that we may see in our clinic routinely, these are families that may have a family history, which would increase your pretest probability of potentially having a type of cardiomyopathy or risk for developing future cardiomyopathy. And also the results of the testing, some of the tests are much more specific, and the sensitivity of the tests tests can also be very valuable. Routine screening for cardiomyopathies in at-risk populations, such as those that have a primary family member with a cardiomyopathy, would include an electrocardiogram or electrical test to screen, not a very specific test. We utilize other imaging modalities to screen many of our children. But as the topic this evening is cardiomyopathy and genetics, you can have normal testing and still be at risk for developing a future cardiomyopathy and be at risk of developing future heart failure symptoms too. As far as severe heart failure symptoms, it's very difficult to predict who will develop those, and routine screening and long-term surveillance of those at risk is something that we spend a lot of our time in our clinic.
Erin, and just to build on that question a little bit more, would you like to comment on the limitations of genotyping predicting phenotypic disease?
Certainly. So, unfortunately, genetic testing does not typically provide us with good information about what to expect. It doesn't allow us to give a specific prognosis in terms of an age that someone might be diagnosed with cardiomyopathy, or even the type of cardiomyopathy. Some of the changes in the same gene may cause a hypertrophic cardiomyopathy in one individual and a dilated cardiomyopathy in another. And so I think there's a few exceptions to that. However, I think for the most part, when you look at a family, you see multiple people that share the same genetic change, and you see quite a bit of variability in terms of age of onset, progression of disease, and severity.
So just as a summation of that, the genetic testing is very instructive because it offers clinicians the opportunity to screen patients long term, but there's really no reliability in looking at what the genetic results are and predicting which patients may go on to need for cardiac transplant, for example. But the real power in the opportunity in genetic testing is simply to be screened, to offer early interventional strategies, and maybe avoid advanced heart failure, end-stage heart failure, which would really be the ultimate goal. So thank you. Very good question. Next question, are there genes besides the 76 heart genes associated with dilated cardiomyopathy? So Erin, would you like to address that?
Sure. So if someone asked me how many genes are there that have been described to cause dilated cardiomyopathy, I would probably give a range because that number is ever changing. And so there are 20 to 25,000 genes that we all have, and there are on the order of 30 or so genes that have been described to cause dilated cardiomyopathy. So there's a number of different genes that can cause the same presentation or the same diagnosis. And so currently when we offer clinical genetic testing, we offer a large multi-gene panel that allows us to, at the same time with one test, look at a number of different genes. How many genes each individual is tested for depends on a number of different things, including their clinical presentation as well as their family history. And so the number of genes that each person should be tested for is dependent upon their own clinical and family histories, as well as really what's available by the genetic testing laboratories at that time. And as I mentioned before, the availability of genetic testing is continuing to change and continuing to evolve, and more genes is not always better. What you want is the right test for you in your specific situation.
And agree, and so are there more genes than 76 responsible for dilated cardiomyopathy? Very likely, and the problem is for us to isolate those genes, to associate them very strongly with the disease phenotype, and then to develop that more into a commercial-based sort of testing opportunity. So there are many research laboratories across the country that are identifying genes every day that may be responsible for dilated cardiomyopathy. That translating into clinical care can sometimes take a long period of time. So the answer is it's very likely there are numerous genes associated with DCM that we don't know about yet, but those will continue to evolve. So moving on to our next question, can noncompaction cardiomyopathy be controlled with medicine? Dr. Wilmot, would you like to take that?
So for some of those in our audience, noncompaction cardiomyopathy has been described in has different names. One of them is left ventricular noncompaction, which is the most commonly used. Noncompacted or hypertrabeculated describes in the left ventricle typically, and the bottom portion of the left ventricle, but it can be in other regions, where there's extra muscle fibers that can be seen on imaging studies. That particular type of cardiomyopathy has a genetic basis that I'll let Erin speak to in just a bit, but that particular type of cardiomyopathy has a very variable presentation clinically. And there are many people that have this type of cardiomyopathy that may not know that they have this because they have no symptoms. We know that the presentation can be variable in the non-compaction population, and we follow a large number of those patients, the pediatric population at our facility. Non-compaction type cardiomyopathy may be a patient who's entirely asymptomatic to someone with severe heart failure, and determining if that non-compaction can, how it's going to progress in the future is something that needs to be monitored over time. Medications can help many of these patients, and we know that early recognition and early diagnosis, as well as medical therapy when indicated, can definitely help patients with non-compaction diagnosis. There's a subset of the non-compaction population that has a normal size of the ventricles, a normal shape, normal function, and has no electrical disturbance. And that population tends to have a better prognosis and oftentimes does not require any medical therapy. In order to determine if you fall into that category is very, very difficult and often only identified by long-term follow-up. Erin, did you want to speak to some of the non-compaction genetic type of testing that may be helpful in determining future care?
Consideration of an underlying genetic cause is important for individuals with a diagnosis of left ventricular noncompaction. Oftentimes the same genes that we would look at in individuals with hypertrophic or dilated cardiomyopathy or genes that we are considering as a potential cause in individuals with left ventricular noncompaction. And I'm speaking really about sort of primary heart disease or individuals that have isolated cardiomyopathy as opposed to an underlying genetic syndrome where other organ systems or development may be affected as well. And so there are certainly some genetic syndromes that can be seen in association with left ventricular noncompaction as well.
And just to sort of clarify the question a little bit, can non-compaction cardiomyopathy be controlled with medicine? So if you're talking about the true phenotype of non-compaction, there's no medical therapy that really changes the degree of trabeculations or recesses that we would see, or the degree of involvement of the ventricle, either the left or the right ventricle. As Dr. Wilmot was saying, it's really dependent on the concomitant cardiac phenotypes in association with non-compaction, whether medications would be helpful or not. So if you have non-compaction in association with a dilated ventricle and depressed left ventricular systolic function, medications can greatly enhance the cardiac function of that particular phenotype. Similarly, if you had an associated hypertrophic ventricle with trabeculations or non-compaction, medical management may help obviate symptoms that would be associated with obstruction or dysrhythmias or arrhythmias such as atrial fibrillation. So the medical therapy associated with non-compaction typically isn't directed at trying to improve or reduce the degree of trabeculations, because we really don't have any targeted therapies that would do that, nor do we see a reason to try and accomplish that. Most of the therapies are going to be associated with myocardial function, whether that's relaxation or squeeze or systolic function, associated rhythms, and the prevention of thromboembolic disease, so preventing strokes, blood clots that may occur in the setting of non-compaction. And then any other advanced therapies that might be needed, such as defibrillators, LVADs, or cardiac transplant. So I hope that clarifies your question a little bit better, and if there's something else we didn't address, please let us know. So moving on to the next question, I have read that Titin mutations lead to poor prognosis. Do you find this to be true, or are the Titin mutations too new to understand the outcomes? So Erin, if you'd like to start and maybe give a little bit of background about Titin and how it's really come on the scene and enhanced our dilated cardiomyopathy panels.
So within the past few years, this gene Titin, which is called Titin because it is the largest known human gene, it's quite large, and the sheer size of it was part of the reason that it took so long to be offered as a clinical genetic test. And it's included in these large multi-gene panels that I had referred to previously. And the data suggests that around 20% or so of individuals with an inherited form of dilated cardiomyopathy will have a variant or a mutation in Titin. I think there may again be some specific prognostic information about certain Titin variants that have been observed more often, or for specific variants in which there's functional data that became available through research efforts. But in general, I think the comment I made in the past about our limited ability to provide specific prognostic information for an individual remains somewhat limited. I will say, though, with Titin and with other genes, is that it can be hugely powerful knowing the underlying cause in a family, as it allows us to determine if there are individuals that did not inherit that genetic variant and therefore can be reassured in terms of their lifetime risk of developing heart muscle disease, and can also give us information about which individuals need to be followed more closely or screened periodically because we know that they have a familial variant in Titin or another gene, so that we're able to detect any changes in heart muscle function at the very earliest stages.
And Dr. Wilmot, would you like to comment whether if you would manage a patient with a Titin mutation differently than an MYH7 mutation in the clinical scenario of dilated cardiomyopathy?
So in regards to that specific question, Titin mutations, as Erin mentioned, as far as prognosis, some of these have been identified with significant phenotypic changes in dilated cardiomyopathy. However, some of the newer ones and some other variants of Titin mutations are not as well known, and I think the prognostic implications with those mutations are a little bit harder to interpret. We know that the MYH7 mutation, as Dr. Jefferies mentioned, is very well reported and very well known to be in specific disease-causing mutations with clinical associations, versus the Titin ones, several of them are not. I think that clinically I wouldn't manage our patients any differently if they had a Titin mutation in addition to their MYH7 or just uniquely a Titin mutation. And this comes back to managing a patient depending on the phenotype that we see. And if this patient has a Titin mutation and has dilated cardiomyopathy and depressed function, the medications that we use are directed specifically for the dilated cardiomyopathy with depressed function in order to enable that ventricle to remodel, to try and heal, and also to improve the function in a long-term situation. It is very useful knowing what the etiology of that is for future family counseling and for future directed therapies at other children that may be at risk for future development of a dilated cardiomyopathy. However, each patient's specific phenotype and clinical presentation can vary, and we tailor our therapy specifically for that clinical situation.
I agree. And a thing to take away is that the initial reports of genetic mutations in association with cardiomyopathy, and most frequently with hypertrophic cardiomyopathy, led to the concept that perhaps specific mutations resulted in worse outcomes, whether those were phenotypic manifestations of disease or risk of sudden death. The more that we do genetic testing, the more that we understand that the presentation of this in the clinical situation is very heterogeneous. And we can't rely on genetic testing, as we spoke about prior, to predict how a patient's going to do long term. And Dr. Wilmot hit on a very key point, is that the etiology funnels into a common pathway of what the phenotype is, whether that's dilated cardiomyopathy or some other phenotypic variant, whether it's hypertrophic or restrictive. And how we manage the patients, I think, is what we've tried to do is very targeted and individualize those therapies to make sure that the patient is getting the best care. The power of genetic testing in those clinical environments is really offering us the opportunity, one, to define the etiology of the disease in the patient, which is oftentimes reassuring to subjects to know why do they have what they have. But more importantly, it's the opportunity to screen at-risk individuals and identify patients who may have had ongoing cardiac symptoms that were undiagnosed, or people that have subclinical disease that can be managed and potentially avert a bad outcome in the long term. So genetic testing in the clinical scenario for us really isn't so much helping us tailor our therapies, but it's more about making sure we're capturing all the patients in the family that may be at risk and getting them plugged into an appropriate surveillance program, which has really been a large part of our program. The growth that we have experienced has been in large part because of that. but it's a very gratifying experience for us as providers to be able to identify those people that maybe have been living with cardiac disease, have been misdiagnosed, or have not been diagnosed at all, and they actually get appropriate therapy and improve, and hopefully we've positively impacted their longevity as well. So thank you for the question. It was a good one. Moving on to our next one, is there a way to prevent cardiomyopathy through in vitro if we lost one baby to dilated cardiomyopathy of unknown cause and no known family history? So this definitely has some strong genetic implications. Erin, would you like to answer this?
So I think an important component to that specific question is that the cause of the cardiomyopathy in the prior child wasn't known. And so unfortunately there isn't a way through in vitro fertilization to prevent the condition in a future child. Now, for individuals with cardiomyopathy where there is an underlying known genetic cause, and this is true for other genetic conditions as well, there is the capability through in vitro fertilization with something called pre-implantation genetic diagnosis that can allow you to identify those embryos that have the genetic risk factor or the genetic mutation prior to implantation, thus reducing the potential to pass on that genetic condition. Unfortunately, if we don't understand why someone had the condition or there isn't a known genetic cause in the family, it's difficult to offer ways to prevent or reduce those risks. And I guess the only thing I'll comment on after that is that, with every pregnancy, everyone has a background risk for having a child with some underlying health problem, whether it's a structural birth defect that they're born with, development of cardiomyopathy later in life, or learning difficulties, things like that. So nobody is without risk, but certainly the family history can inform us about specific risks for families as well.
And what would you suggest for families that prenatal counseling, what's a good opportunity or a good use of a visit with a genetic counselor that maybe would help people to get plugged into the right system?
Yeah, certainly. So for couples that are not yet pregnant, or if they are pregnant, but oftentimes a good time to meet with a genetic counselor if there are questions about your specific risks for having an affected child. We do offer preconception genetic counseling. And so we can meet with couples, take a detailed family history, talk with you about your own medical histories, and offer you screening tests, whether it be clinical screening tests like specific ultrasounds to look at the baby's heart during the pregnancy or after the baby is born, as well as some genetic screening tests as well. So certainly preconception is a good time to meet with a genetic counselor if you have specific questions.
Great, and thank you. Moving on to our next question, is cardiomyopathy male-dominated? And I'll ask Erin to weigh in on that initially, and we'll add some more information.
So in terms of the inheritance of familial cardiomyopathy, the vast majority are what we call autosomal dominant. This term autosomal just means that the genes that are involved in causing these conditions are not on the X or Y chromosome. They're on the chromosomes that men and women, males and females, share. So the inheritance typically is not male dominated. There are some inheritance patterns, one in particular called X-linked, which means that the gene that's causing the condition in the family is on the X chromosome. So you probably all know that females have two X's and males have an X and a Y. And so for many conditions that are X-linked, either males are affected and females are not, or males may be more severely affected. That's not always the case, but there are some genes that can cause cardiomyopathy that are X-linked, but they're the minority.
Yeah, and absolutely true. And we actually follow some large cohorts of those X-linked cardiomyopathy patients. And Dr. Wilmot, I don't know if you'd like to comment a little bit about some of our Duchenne or Barth populations, and then maybe also bring in the idea of carriers, and does that actually predispose some females to cardiomyopathy?
So specifically speaking to the X-linked population, which as Erin mentioned is a subset of the population, our X-linked population that we follow, as Dr. Jefferies mentioned, some of the large cohorts include our Duchenne's and Becker's muscular dystrophy patients. In those patients, they have a defect in the dystrophin gene, which affects not only their cardiac muscle, but their skeletal muscle as well. We follow a large cohort of patients at our facility, and because this is an X-linked defect, we see a significant large number of boys that carry defects that they actually do not make any true functional dystrophin in the most severe forms. Those patients develop dysfunction of their heart, dilation of the heart, and develop a dilated cardiomyopathy and are also at risk for developing future arrhythmias. In those young men that develop that cardiomyopathy, heart failure symptoms can present, and early diagnosis and recognition of those changes in their heart and early intervention with medications can also help to slow the progression of fibrosis and scarring in the heart, and can also direct therapy in their future care. With regards to carriers, oftentimes the mothers of these young boys will be carriers, meaning that they carry one dysfunctional dystrophin gene and one functional dystrophin gene. And those moms are also at risk for developing skeletal as well as cardiac disease, and can also develop dilated cardiomyopathies, arrhythmias, and dysfunction. In the past, many of these carrier moms, as well as carrier siblings, similar to the boys, the girls can be carriers, or similar to their moms, the girls' siblings can be carriers as well, and they too could be at risk in the future. We run a carrier clinic here at Cincinnati Children's Hospital that runs jointly with our Duchenne's clinic. And those moms are seen. We follow moms of all ages, and we follow siblings of all ages that may be at risk that are carriers as well. And routine screening in those patients is also recommended to identify those changes in the ventricle where interventions can definitely change the clinical outcome.
And so just to summarize, the majority of cases we deal with, there's really no sex preponderance, male-female, equal probability. But with these X-linked conditions, some of the previous sort of misconceptions about these diseases is that carriers were not predisposed to cardiovascular disease, and that's increasingly been refuted in multiple populations. As Dr. Wilmot alluded, we have a very large carrier clinic for dystrophinopathies, but also large populations such as Fabry disease and other cohorts which are X-linked. And really the takeaway from that perspective is that females that are known carriers should likely be involved with a cardiologist because their risk is there and never goes away because of the genetic trigger behind the disease. And it takes a thoughtful approach to make sure that surveillance is done longitudinally, and we would suggest that to be considered lifelong. So with that, great question. We'll move on to our next one. Is there any overlap between dilated cardiomyopathy mutations and mutations linked to aortic aneurysms? So we'll talk just brief as a primer about dilated cardiomyopathy. We really haven't talked about what that means, but dilated cardiomyopathy is a heart muscle that's dilated beyond what we would consider to be normal limits. The mass or the myocyte sort of volumes of the heart are increased, and then the heart squeezes down, and so it's concomitant systolic dysfunction. And then this question about aortic aneurysms, where we're talking about the large artery leaving the heart potentially being dilated, and that's what the aneurysm is referring to. And for the purposes of this question, we'll refer specifically to thoracic aortic aneurysmal disease. So those are the ones that are thought to be more genetically triggered. And the question I think is getting is, would there be some overlap between mutations known in DCM and people having thoracic aortic aneurysmal disease? So Erin, I'll ask you to give your thoughts on that question.
Sure. So I guess just a bit of background when someone says DCM mutations, just so that we're all thinking about things in the same way. These genes that we know can cause cardiomyopathy, we all have them. Everybody has them. In fact, we have 2 copies, one from our mother and one from our father. And all a gene is a segment of DNA, or a specific segment of the DNA code that makes a protein. And that protein is then what performs the function in the body. So when we do genetic testing, what we're doing is sequencing that DNA code. And the way I often talk about it, or an analogy that I sometimes use when I'm meeting with families, is it's like spell checking a Word document. So you're spell checking the gene, looking for a misspelling that would cause the meaning to change. And so the genes that are most often associated with dilated cardiomyopathy, or that most often have an underlying genetic mutation or variant, as far as I know, have not been associated with familial causes of thoracic aortic aneurysm. In fact, when we think about thoracic aortic aneurysm as an isolated disease, we certainly know that there's a genetic cause, but our ability to identify a genetic cause in the vast majority of those families is quite poor. So to date, that's not a known link, at least in the genes that we most often think of as causing dilated cardiomyopathy.
I agree. That's an excellent answer. We do have some research going on where we've looked at it in the opposite direction. So not so much looking for DCM genes, which are usually what are called sarcomeric genes, and we'd be happy to provide a more extensive list and an explanation for that. But we do know genes, some of the genes that are responsible for thoracic aortic aneurysmal disease. And one of those genes is a gene that codes for a protein called fibrillin. And that we actually have seen mutations in that in association with patients having left ventricular noncompaction. So that's something that we're looking at, that's a little bit different than what was asked about dilated cardiomyopathy. But there are some potential signaling pathways and other things that could be implicated in both phenotypes, but we don't really know a lot about that at this point. And what we would say is, as Erin stated, is that the known genetics behind dilated cardiomyopathy and the known genetics behind thoracic aortic aneurysmal disease really don't have a lot of commonality or overlap. But recognizing we still don't know the majority of DCM genes, we still don't know the majority of thoracic aortic aneurysmal genes, is there a possibility for that to exist? Absolutely. So we'll get moving to the next question, which is, I think, a very practical question, very pertinent to what we're talking about today, would be what is the process of getting tested for children? And this is an open-ended question. We'll talk a little bit about the genetic testing, and then we'll also talk about the phenotypic testing. So Erin, if you'd like to start with the genotypic testing.
Sure. So from a genetic testing standpoint, the logistics or specifics are really not different for people from infancy to adulthood. So most of the time, the actual testing process is done on a blood sample, just a small sample of blood, as I'm sure many of you have had done for other reasons. And the sample is sent to a genetic testing laboratory. The test that's requested or the genes of interest are sequenced, and then the results are given back to the healthcare provider. At our institution, it involves a team of people, but typically the genetic counselor will receive the results, will review those results, will interpret them in the context of that individual's family, and will communicate those results back to the family. One of the nice things about being part of the Cardiomyopathy Heart Failure Clinic is that patients and families return for screening at various time points. So not only are we able to communicate results with patients and families by phone, but we're able to see them periodically to provide them with updates, because the interpretation of genetic testing results can change with time. Sometimes the specific family history information changes. Other times our knowledge changes about a specific variant, and the way we interpret it and the recommendations for families may evolve. And so we have the opportunity to communicate that information back to the family periodically.
And so recognizing genetic testing is hugely valuable and a powerful leveraging tool when we can identify a mutation. For many years we practiced cardiology and screening for cardiomyopathy without the advantage of having genetic testing results. How would we approach someone, Ivan, who came in with a family history and we had no real knowledge of their genetic substrate?
So that's a good question, and I think a lot of our screening is identifying at-risk populations, and some of those at-risk populations we can identify with family history, and increasingly we're identifying families that have significant family histories of, as you mentioned, the carrier status of some of our Duchenne's populations, but we also identify patients that have had abnormal screening. Some of our patients are identified with routine screening in pre-health physicals and are identified that way by either listening on exam, and some of our cardiomyopathies are identified by abnormal exams. Some of them are identified with abnormal electrocardiograms, as mentioned, as one of the screening tools. These tests are not perfect in identifying everyone that is at risk, and I think that's very important for our audience this evening to understand. And so it is important when there is a concern, either family history or other concern for cardiomyopathy, to seek out evaluation by someone trained in cardiomyopathy. In our clinic, we spend a lot of time utilizing both our clinical skills as well as our genetic tests in order to identify who may be at risk. And some of those clinical tests that we use, as mentioned, one was the electrocardiogram, one is the echocardiogram, and a lot is our history in obtaining additional information from families. And on follow-up, as Erin mentioned, we often, with deeper delving into some of the family history, identify more information that actually solidifies why there may be a family history of a certain type of cardiomyopathy. We identify many patients with echocardiogram with a dilated heart, as Dr. Jefferies mentioned, and then following identifying, say, a dilated cardiomyopathy, we'll seek out with genetic testing, as Erin mentioned, and identify the etiology. Even if an etiology is not identified with current genetic testing and the limitations of that testing, we would also recommend additional family screening of other family members with clinical screening to identify if they too are at risk of having a dilated cardiomyopathy. As mentioned, genetic testing can be very powerful, but it's also not perfect. And that is why we would also recommend in this clinical setting testing some direct family members in certain clinical scenarios.
Dr. Wilmot alluded to a very important point that I hope everyone watching takes away, is that if you're really going to be managed and screened, we would encourage you to seek out providers that are familiar with cardiomyopathy and the potential opportunities, whether they're clinical or genetic testing based. And remember that if you feel that, if you or your provider feel that this is a strong possibility that you're at risk for a heritable cardiomyopathy, there's some genetic trigger for this particular disease process, this is a lifelong surveillance program. And so part of that is clinical surveillance and meeting with a cardiologist who is familiar with what they should be looking for and using the right kind of test to make sure that there's no cardiac involvement, or if there is cardiac involvement, that appropriate management strategies are employed. And recognizing that this has to be done in a lifelong fashion. Very similarly, as Erin has alluded to in the past about genetic testing, genetic testing may be done on you or your child and the results may be negative. But periodically we revisit those tests, we add to those tests, new genes are implicated in the disease. And the idea of repeat genetic testing in the future is something else that should be considered. All of those things are typically going to be housed in an environment where people are very familiar with the causes for this disease, for these diseases, and most importantly, what are the long-term implications not only for the patient but for the family in general. So I do hope that everyone recognizes that if you have access to those sorts of providers or that sort of level of care, we would encourage you to do that, because I think it has an important implication for you or your child, but the rest of your family as well. So moving on to the next question, and this is one that we see very frequently, at least 3 or 4 times in a clinic usually, but it's very pertinent, I think, to the discussion, is does insurance cover genetic testing, and what would be the associated cost, which I'm presuming would be to the patient or to the hospital potentially. So Erin, would you like to talk about that?
Yeah, so I think it's a very important question, and I think we all are becoming much more proactive about our use of healthcare, including genetic testing. And so cost is something that I always talk about with patients and families when I meet with them. So I'm debating about how to answer this question. Does insurance cover the cost of genetic testing? Yes, sometimes. And so here, we're specifically talking about cardiomyopathy gene testing, but of course there are lots of other types of genetic testing as well. And so whether or not insurance covers the cost of testing depends on a number of things. Sometimes it's the specific insurance policy and whatever their requirements are. Other times it has more to do with the patient's specific diagnosis, the family history, how suspicious are we of an underlying genetic cause. But I think, again, working with someone who is familiar with this type of genetic testing, that frequently orders this type of genetic testing, can help make sure that you have the best chance at accessing the information if it's indicated. In terms of what's the cost, so if you're talking about testing in the initial person in the family, so we're doing a large multi-gene panel for somebody with a diagnosis of hypertrophic or dilated cardiomyopathy, the cost of that gene panel ranges, depending again on the laboratory, probably probably anywhere from $1,500 to $5,000 if you were going to pay the list price of the test. I can tell you that most people don't pay that for genetic testing. If you know what the specific genetic variant is in the family causing disease, and other people are having family-specific testing, or what we call known variant testing, the cost is substantially less. It's on the order of a few $100s, and again, insurance does often cover that cost of testing. And I'll take just a moment. I think oftentimes people hear genetic testing and there can be some confusion about the difference between clinical testing and research testing. And we certainly talk with our patients about both, but the testing I'm talking about currently is clinical genetic testing. There are guidelines and consensus recommendations indicating that genetic counseling and testing should be offered to families with suspected familial cardiomyopathy. And so this is a clinical test. It's not a research-based test. It's done by an accredited laboratory, and it would be a test that would be billed to your insurance company and payable by your insurance company, presumably.
And part of this does revolve around phenotype when we talk about guidelines. And for hypertrophic cardiomyopathy, for example, it's strongly recommended that genetic testing be considered. And it should be a strong consideration for people with dilated cardiomyopathy for restrictive or LVNC. So you need to weigh those nuances in when you talk about genetic testing. But remember, we feel that the power in genetic testing, there is a potential associated cost, and you want to be in a system where that can be mitigated in an appropriate way. And you want to be in a system where we're very fortunate where we have genetic counselors to help us to relay the information of the results of that genetic testing in an appropriate way to the family, and then potentially trigger cascade screening for all those at-risk individuals. So you do want to be in that sort of a system. But as we said, many patients that have come to us as what we would consider an index case, the results of genetic testing have resulted in multiple family members being identified and screened and even treated for cardiac disease. So recognizing that there are potential costs associated with it, but there are potential benefits to genetic testing that really can't be quantitated in my mind. If you can impact the outcome of a family, not just a patient, that's a hugely worthwhile investment, at least we believe, on the patient's part as well as on our providers' parts. So our next question is moving a little to a different phenotype a little bit. We've talked a lot about dilated cardiomyopathy and noncompaction. We'll talk about hypertrophic cardiomyopathy, and the question was, what are the treatment options? So just as a basic sort of background for hypertrophic cardiomyopathy, a very potentially serious cardiomyopathy. About 1 in 500 people have hypertrophic cardiomyopathy. That underrepresents the people who have genetic triggers for have this disease, and it probably underrepresents the people that actually have phenotypic disease. There are many people out there walking around with hypertrophic cardiomyopathy that we don't know about. But this question is specifically related to someone who had known hypertrophic cardiomyopathy. What would be the treatment options? So Dr. Wilmot, what would you think about treatment options for HCM?
So treatment options for HCM can be divided into different categories, and medications could be one of the categories. Advanced therapies can be one of the categories, and for some of those patients with very severe types of hypertrophic cardiomyopathy, we rarely but sometimes utilize surgical interventions as well. Hypertrophic cardiomyopathy, as Dr. Jefferies mentioned, is thickening of the middle portion of the ventricle called the ventricular septum, which can lead to obstruction and can lead to the ventricle not relaxing very well, and can lead to difficulty with the blood ejecting or getting pushed out of the heart. We often use medications that help to alleviate some of those problems. Some of the medications we use are in a family called beta blockers, which help to slow the heart down and allow it to fill with more blood, and also prevent the heart from beating very fast, which can sometimes lead to more obstruction, and that can actually alleviate that type of problem. The other categories of medicines that we use are sometimes other medicines in a family called calcium channel blockers, and those medicines can similarly help to slow the heart down in a scenario where there's significant obstruction. We also utilize advanced therapies sometimes when we have patients with hypertrophic cardiomyopathy that develop arrhythmias, and patients with hypertrophic cardiomyopathy are at risk of developing arrhythmias, and specifically life-threatening arrhythmias, which are in a category that sometimes is explained as ventricular tachycardia, which is where the bottom chambers of the heart have very fast beating, and this can be life-threatening and can actually lead to sudden death events. And these are some of the events that you may have heard of with young athletes that are identified after a exercise type event or a football type event. These can be associated with sports, but they can also be not associated with sports. So identifying patients with hypertrophic cardiomyopathy and identifying who may be at increased risk in that population is essential. These advanced therapies that we're talking about are really for those patients with the more severe phenotype or very, very thick muscle that separates the two chambers or ventricular septum, patients with ventricular tachycardia, or events where patients have had these sudden death events where they've actually been able to intervene and save them, so an aborted sudden cardiac death event. In that scenario, we talk about pacemakers that actually have a defibrillator type capacity. So these are implanted devices that have a defibrillator capacity, similar to the devices that you may see on the side of a sports field or in a school, or that are quite pervasive throughout society now because of this risk. That type of device would only be installed by some of the specialty cardiologists that specialize in putting these devices in, but they can be life-saving to those patients that are at significantly high risk. Some of the other therapies, if we move on to the surgical side, for very specific patients that have very thick ventricular septums with severe outflow tract obstruction that are resistant to some of these medical therapies that we're talking about, those patients can develop very, very thick hearts that don't relax very well, and that can lead to significant symptoms of heart failure, but can also lead to significant risk of developing sudden cardiac death. And in select populations, we will actually recommend patients that are symptomatic specifically that they actually have a surgical procedure where they actually shave part of the muscle between the two ventricles, that ventricular septum, to alleviate some of that outflow tract obstruction. And that can actually be very beneficial in select populations. Additional therapies for some of our patients that have very severe hypertrophic cardiomyopathy resistant to medications, advanced therapies, as well as surgical interventions, a very, very select few may undergo evaluation for heart transplantation. That is not common, that is very uncommon in our population, but there are some patients that do require that because of very advanced phases. And we try and risk stratify our population here at Cincinnati Children's to identify which of our patients have lots of injury to their heart muscle, and we utilize cardiac MRI and additional advanced imaging to identify those patients that may be at higher risk of developing these life-threatening type of events, and also to try and identify the optimal timing of intervening with some of these advanced therapies as mentioned.
And so to summarize, the excellent response is that most of the therapies really are targeted either at relieving obstruction, so that and that's where those medications would often come into play, and the other components really are based more about dysrhythmias or arrhythmias, which could consist of ventricular tachyarrhythmias or things like atrial fibrillation, and consideration of therapies not only for trying to mitigate those arrhythmias, such in the setting of atrial fibrillation, you might require blood thinning medication, for example, but also consideration of a device such as an ICD. Dr. Wilmot alluded to some of the pathophysiology of hypertrophic cardiomyopathy, and a lot of it has to do with the formation of scar tissue inside the heart, which we can characterize with cardiac MRI. Some of the newer therapies that are on the horizon for HCM are very exciting because they may actually target that particular component, which is the development of scar. Scar is thought to be the nidus for many of these fatal arrhythmias that we deal with, as well as some of the relaxation abnormalities that are well noted in patients with hypertrophic cardiomyopathy. And if you're interested in learning more about those particular therapies, they're under research protocols right now. Please feel free to contact me, and I can increase your sort of awareness of what's out there and what might be a possible therapeutic strategy targeted not only at scar burden, but also the ability to help the heart muscle relax. So if you are interested, please let us know and we can provide more information. So moving on to our next question. How can someone have cardiomyopathy yet have negative results when genetic testing takes place? I have hypertrophic cardiomyopathy. So recognize, as you've been hearing, is that genetic testing is not perfect, and we don't know all the genes for any one particular cardiac phenotype. We do know the most about hypertrophic cardiomyopathy from a genetic trigger perspective, but I'll ask Erin to offer more information about what would be our pretest likelihood of identifying a causative mutation, and then what are your thoughts about those other 30% or so that maybe we don't find?
Sure. So whenever we meet with a patient or a family, we talk to them about the pretest probability or the yield of genetic testing. What are the chances, or how likely do we think it is that we'll find the underlying genetic cause with this test that we're recommending? And the likelihood of identifying an underlying genetic cause for HCM is relatively good compared to some other genetic tests, but does depend in part on specific things: how old someone was when they were diagnosed, how many people in the family are affected, and even to some degree the specific areas of the heart muscle that are thickened. In general, you can think about the yield of genetic testing for hypertrophic cardiomyopathy probably to range from 50 to 70% or so, but that's far less than 100%. And so we certainly have families where there's multiple generations affected, and you don't need one of us to tell the family that it's genetic. They know. And yet our testing still fails to identify the underlying cause. So why is that? It's possible that there's a gene that wasn't specifically tested for, and it's not that that test is available out there now. It's a gene that we either haven't identified or don't understand its relationship with this particular type of heart muscle disease. And I think, too, probably some of the genetic causes for these individuals with HCM who have had normal clinical genetic testing to date is that it's not a single gene. We're getting better at identifying single gene causes for diseases, but how different genetic variants interact is much more complex, and we aren't nearly as good at that. And so it may be that for some of these individuals, it's not a single gene, single disease scenario, but multiple underlying genetic causes. I think the thing I would say is that even if the genetic testing is normal, that it would be beneficial to assume that there's an underlying genetic cause and to offer cardiac screening to at-risk relatives. So that typically is first-degree family members, parents, siblings, children should have periodic cardiac screening and should be considered at risk based on the family history, even if genetic testing is normal.
Hypertrophic cardiomyopathy is a genetically triggered heart muscle disease, and if that genetic trigger was not identified on the initial screening, then that just means that at some point in the future, revisiting the scope of testing should be entertained, and potentially there will be an identified cause at some point in the future. So along that same line, we'll go to the other end of the spectrum where maybe we don't know as many of the genes. And there was a question about dilated cardiomyopathy. We've been told there's currently only a 40% likelihood of identifying the gene that is responsible for the genetically triggered form of dilated cardiomyopathy. Is this correct? Should we assume if a grandmother who is diagnosed at 72 years of age and her son diagnosed at 42 years of age, that this is a genetic condition? And so, Erin, would you like to speak about that?
Yeah, so the question about the likelihood of identifying an underlying genetic cause for familial DCM, so a parent and a child that are affected, I would say 40% is an appropriate estimate. So it's our sensitivity or our ability to identify the underlying genetic cause in dilated cardiomyopathy is less than for hypertrophic. And if you're asking me if I think that's a genetic condition, yes, I do. And similar to my comment about the prior question is that other family members, so parents, siblings, children of individuals that have a diagnosis should be offered screening. I think it is a genetic condition. We just simply have not yet identified the underlying cause.
And just to further characterize the sort of clinical component of this, I'll ask Dr. Wilmot to weigh in, but we would want to confirm that the diagnosis in the grandmother was not from an ischemic etiology. So recognizing there are many pathways that one can develop dilated cardiomyopathy, and that can be from other end organ dysfunction, that can be from other causes such as coronary artery disease and ischemic myopathy, that can be from problems with endocrine function, that can be acquired disease, so in the form of drug exposures and other things. So based on the scenario, Dr. Wilmot, what would we be doing, you think, for this when this grandmother comes in, recognizing that we have a less than 50% chance likelihood of hitting a positive genetic trigger? What would we suggest for this family when she came in to see us in clinic?
I think at first, one of the items that I would like to clarify, and similar as what you mentioned, Lynn, is that I would like to clarify that this is actually a heritable or familial type of cardiomyopathy, because there are a lot of acquired cardiomyopathies when someone is of that age. And this may be a mixed picture. There may be coronary artery disease. There may be other risk factors for this grandmother who has developed a dilated cardiomyopathy, hypertension, and significant other things. Identifying when the dilated cardiomyopathy was actually diagnosed would be valuable to us clinically. If this is a long-standing dilated cardiomyopathy prior to any other risk factors, that would be more convincing for a heritable type of dilated cardiomyopathy. In addition, the other family member that you mentioned that was in their 40s that is affected, you'd want to identify more clinical information if there was any symptomatology, when this developed, when the screening was done, and then also the type of screening that was utilized can be very valuable. MRI screening in many of our older population has a very high resolution. Echocardiogram type imaging in our older population is not quite as detailed. And that's limited somewhat by just anatomy and development as you get bigger. MRI also, as we alluded to, has the ability to evaluate for some evidence of injury or permanent injury or fibrosis in the myocardium as well. And if the particular family member, the grandmother in this situation, had that type of imaging in the past, that would be very beneficial for us as far as clinically to try and identify if this was in the heritable cardiomyopathy population, or if this was in an acquired type of category as well. If this was a heritable type of cardiomyopathy and this was identified in the grandmother and she was identified to have the dilated cardiomyopathy as mentioned, then I think, as Erin mentioned, even though the genetic testing now is limited, that could be something that could be valuable in this family as far as future testing. Even though it's limited at around 40%, as was mentioned, that can be helpful for other family screening.
And Erin, maybe just comment for everyone, when we talk about family screening and cascade testing and these sorts of things, if someone presents to our clinic, and let's say it's the 42-year-old gentleman that was just referenced in the question, how would we approach that individual from a pedigree perspective, and who are the at-risk individuals that we would suggest testing, whether that's clinically based testing, imaging, electrocardiography, or genetic-based testing? How would we approach that individual?
Sure. So when you approach genetic testing initially in the family, you want to start by testing the most severely affected. That doesn't sound quite right, because not everybody that we're testing is severely affected, but you want to test someone who has a well-confirmed known diagnosis of disease. And so if you are successful in identifying the underlying genetic cause in that individual, you could then offer family-specific testing to first-degree relatives. So for the 40-year-old, it would be that gentleman's children, and they would have a 50-50 chance, most likely, of having inherited the genetic variant identified in him. In addition, we would test his parents as well as his siblings. And depending on our confidence in the disease-causing interpretation of that particular variant, it may also be appropriate to offer cardiac screening, most likely with a cardiac evaluation with a cardiologist, an electrocardiogram, as well as an echocardiogram in the at-risk individuals. If we aren't able to identify an underlying genetic cause, then you would want to proceed with cardiac screening in all of those at-risk relatives.
And just to clarify, if in, let's say, the 42-year-old, we did screen one of his siblings, and it turned out that we found a mutation, or that maybe had phenotypic evidence disease, we'd be screening his children, and so on, and that's where this idea of cascade screening comes into play. It's very important for people to understand that, because once again, that's the real powerful aspect, I think, of what we do, is identifying those at-risk individuals. We will finish up with one last question, and that question is, how and where should I get tested? And that, once again, is an open-ended question. So we'll talk a little bit about genetic testing, and we'll also talk a bit about more clinically based phenotypic testing.
So I think how and where, the first step, I think, is to find a healthcare provider that is knowledgeable about this and can help you navigate the process. I would suggest starting with an existing healthcare provider. If you have a cardiologist, ask them if this is something that they do, or if they refer. If you're interested in finding a genetic counselor, you're certainly welcome to contact me. If you're not in the Cincinnati area, I can help you find someone closer to where you live. You can also go to our National Society's website, nsgc.org, community. There's a Find a Genetic Counselor tool there, and you can search for counselors by expertise and by zip code if you are looking for someone closer to where you live.
Dr. Wilmot, clinically test?
On the clinical side, as far as testing, there are also many centers that have cardiomyopathy testing. That we would recommend finding a reputable center that has cardiomyopathy expertise. As far as evaluation, we too would be happy to facilitate identifying someone in your area if you do not live locally. And locally, if you do live in the Cincinnati area and you want to find out more about future testing, what testing is indicated, or if you want to be evaluated in our clinic, we'd be happy to help facilitate that as well. We facilitate, as was mentioned, carrier testing for those X-linked type of disorders, as well as many other disorders as well that weren't discussed this evening. But we'd be happy to help direct some of your future care if that is something that you would find beneficial.
So we want to bring our session to an end. I want to thank my co-panelists. It's very thoughtful questions, and we've covered a lot of area, and we appreciate your input, and hopefully you've found some useful information. We do want to thank you again for joining us, and in the next few days we'll provide you with a link to the recorded event, and as I alluded to earlier, we will make every attempt to provide answers to any other questions that weren't addressed directly during the chat. And as for you've heard from all of the panelists, if there's anything we can do to better inform you the care of yourself or your family or your child, please do not hesitate to contact us. You can call 1-877-881-8479 for more information about our program. And with that, thank you and good evening.